people that has a scleroderma section that has 6 people who devote their practice to treating all of the medical conditions of people, excuse me, who have scleroderma. So as a result, I get to take care of a number of their patients who have hand issues related to their scleroderma. Pretty much all of the photos that I'm showing here are photos or x-rays of patients I've taken care of. And again, feel free to interrupt with questions if you have them. So things you may already know, about 19 million patients in the US have scleroderma. Symptoms and finding include non-inflammatory tissue fibrosis, collagen deposition, vasospasm and vasoocclusion affects multiple organ systems, but where people come to see me for it, they're generally talking about it affecting the hand. Limited cutaneous scleroderma affects hands more often, meaning patients with that have hand symptoms more often than patients with diffuse scleroderma do. And of course, the crest subtype, the calcinosis is typically affecting the hands, Raynaud's, and then those patients also have esophageal dysmotility in addition to sclerodactyly and telangiectasias. There are 3 main types of hand symptoms that I take care of in my scleroderma patients: calcinosis, vasospasm or Raynaud's phenomenon, and joint contractures that may or may not have accompanying ulcers. The vasospasm may also have its own share of ulcers. Calcinosis affects about a quarter of patients with scleroderma. Interestingly, the patients have normal metabolism of calcium, meaning their kidneys handle calcium normally, their gut handles calcium normally. It's thought to be a function of blood flow into the fingers or why they get these depositions. And there are 2 main patterns of the calcinosis. Some patients will get well-defined small deposits at the distal end, the far end of the fingers, that sometimes will even extrude or come out on their own in things that look like little white pebbles. But more often I see patients with diffuse calcifications along the length of the digit. When you look at these on x-rays, they look almost like little cloud-like formations. And you can often tell the difference of what it's going to look like and feel like surgically based on what it looks like on an x-ray. Not everybody with calcinosis needs surgery. The people for whom I consider calcinosis surgery, generally speaking, have discrete deposits, and they're often having symptoms related to it. They're either having pressure-related pain, they may have started to extrude some of the deposits, and in the process of extrusion, some of those deposits may have even become infected. If somebody is asymptomatic, even if you can feel the deposit, but it's not bothering them, it's not hurting them, it's not looking like it's about to come out on its own, I will often leave it alone. Also, surgery is not curative for calcinosis, even in the area where we do it. And so really making a well thought out decision about, is this deposit on your finger bothersome enough that it's worth kind of the risks of going through a surgery, the risk of wound healing issue. I'm a big believer in judicious excision of symptomatic calcifications. I make small incisions in the skin, and my primary instrument for removal is something called the Curative, which if you haven't seen one, it looks like a little tiny ice cream scoop. And my rationale is I want to take the pressure off of the overlying skin because 1, that's what hurts, and 2, that may be what is or is about to extrude through the skin. But number 2, I want to make as little of a burden on the finger of a wound that needs to heal as I can. And so these incisions are often slow to heal. Sometimes they'll even separate. So I don't want to make a large incision that has a bigger area at which there's a risk of breakdown. This photo on the bottom is actually not a patient who I operated on, but a patient who came to see me after having surgery in another state by someone else. And an incision that was a well-planned incision and of an orientation that in somebody who didn't have scleroderma would do very well. Unfortunately, on this patient went on to break down, and it took us a number of months, I think even over a year, to get it healed. Some surgeons, if you read the research articles, will recommend a radical, a tumor-like excision, and then do soft tissue reconstructions with skin grafts or local flaps or things like that. I personally am not a big believer in that. Again, I worry about the ability to heal, so I don't want to make a large wound that has to heal. Moving on to Raynaud's phenomenon, in many patients, it's the first sign of what will eventually get diagnosed as scleroderma. Nearly everybody with scleroderma has Raynaud's to some degree. As you all know, it's provoked by cold exposure or by stress. The fingers then go through a cycle of becoming pale, then blue, then red and flushed, and it's typically very painful. Some of these will progress to ulcer or even gangrene at the tip of the digit. For the patients with Raynaud's, I'll often start with the device you see in this image here, what's called a pencil Doppler, just to look at the large arteries feeding into the hand and then the artery kind of at the base of the palm. If that shows abnormalities, some patients I will send up to the vascular lab to get more formal ultrasound studies. Once in a while, I'll find a patient who has a blockage that we can do a bypass. These are much more commonly done in the leg for patients who don't have scleroderma. Once in a while, you'll find disease in the hand. Ms. Levy, I think you raised your hand. Yes, you're on mute though.
Can you please tell people to mute, because there's a big interference that we're hearing.
Okay. Yes, if everybody would please mute.
Thank you.
Okay, hopefully that will help. So unfortunately, it's only a small subgroup of my scleroderma patients who actually do have a localized enough blockage in their blood vessel that we can actually do a bypass. What I mean when I say a bypass is there's a reasonable blood vessel up to a point, then it stops having flow, and then there's a reasonable blood vessel on the far end, and we can borrow a piece of vein or a piece of artery from a non-critical area and literally make a bridging pipe. Unfortunately, in most of my patients with scleroderma, their artery disease, either one is of the very small vessels that are too small to do bypasses for, or is over too large of a span of the artery to reasonably do a bypass. If one of my patients is a candidate for that, that actually gives me the opportunity to really improve the blood flow to the hand. But unfortunately, it's only a small subset of patients who are candidates for that. Moving on to Raynaud's, where there isn't a blood vessel blockage that we can treat surgically. Again, most of these treatments, you know, minimizing cold, minimizing stress exposure. Many of you are on blood vessel dilators, something called calcium channel blockers like amlodipine, nifedipine, or felodipine, nitric oxide synthetase inhibitors, sildenafil, which fortunately in the last 5 or 10 years has come under a different brand name, Revatio. When it first came on the market, some of you may know it also goes under the trade name Viagra. And so having to explain why as a woman you're getting Viagra, sometimes that's confusing to a pharmacist. So now there's a different name for when it's used for these reasons. Unfortunately, many patients with scleroderma have low blood pressure, and these medications dilate, make larger all of the blood vessels, which unfortunately means there's limitations to how high a dose or even if any dose can be tolerated in somebody with scleroderma, because for many patients, before they get much blood vessel dilation to help their fingers, they get blood vessel dilation that makes their blood pressure too low and they feel lightheaded when they stand up. So unfortunately, that's often a rate limiting step in terms of how much we can use these. Another issue is sildenafil. Many insurance carriers will not approve it because it's an off-label use. Another thing that we do both surgically and medically is something called a sympathectomy. The idea of this is Raynaud's blood vessel spasm is caused by the smooth muscle in the blood vessel overreacting and squeezing down. If we could find a way to turn off that signal that makes the blood vessel spasm, we can make the blood vessels larger, get better flow to the hand, fewer and less severe Raynaud's phenomenon, healing of ulcers, all sorts of good things. I'll talk a little bit more about that. The good and the bad of a surgical sympathectomy is, number one, it's a trip to the operating room. So for my scleroderma patients who do have lung or airway or facial disease, we worry about making you sleepy and making it harder for you to defend your airway, to keep, that sort of thing from a systemic safety standpoint. But also, once we act surgically on these blood vessels, even as precise as we are, generally speaking, we can't do it again. This is generally a bullet we can only fire once. We can sometimes work on a different section of the artery, but for any section of the artery that I've operated on, generally I get it as good as I can, but I know that realistically it probably won't be safe for me to go back there a second time. So is there another way? Well, beginning in the late 1990s, early 2000s, some hand surgeons and plastic surgeons started investigating the use of Botox. Yes, this is the same Botox that's used cosmetically for wrinkles and things like that. It's also used for migraines, to see if you could get a similar effect with an injection, something you could do in the office without a trip to the operating room, even if it didn't last as long, but something that would come at much lower risk. And the idea is you're going to chemically mimic what we would be doing surgically to disrupt the nerve signal to the blood vessels, get them to dilate. Dilated blood vessels provide better blood flow. Better blood flow provides fewer and less severe Raynaud's episodes and healing of ulcers. It has the upside, it can be done in the office. Now, for those of you who've had it done, it does mean 7 needle pokes per hand. So it's not the easiest thing to go through, but certainly an easier thing than a trip to the operating room. Other things to be aware of, it doesn't work for everybody. The patients who it tends to work best for are people who've had scleroderma for a relatively shorter time. Now, relative shorter time actually just means 15 years. So that's still a fairly large time frame. Patients who have limited rather than diffuse scleroderma, and patients who are on calcium channel blockers, which in our research study, we took that as a proxy to say they're having more blood vessel spasm and less scarring on the blood vessels. Scarring on the blood vessels, we don't think it's affected by the Botox, but the blood vessel spasm can. This is an off-label use. So like sildenafil, many insurance carriers won't pay for this. And to pay for a vial of Botox, 100 units out of pocket, is about $600. Interestingly, Medicare, which is not an insurance carrier I would normally think of as being accommodating of things, is the insurance carrier that I have the least amount of trouble getting authorization for, which going into this, I would not have expected that. Moving on just briefly to talk about surgical sympathectomy, this operation has actually been around for many decades. And the idea behind it is if you could disrupt just the nerve signal going to the muscle around the blood vessel, the muscle would do its regular job, but it wouldn't spasm down and reduce blood flow. And it may help with reducing the frequency and severity of Raynaud's episodes. It may allow ulcers to heal. It can't reverse gangrene, but it can stop gangrene. And again, this does mean a trip to the operating room. And generally speaking, we get one opportunity per vessel. So we can work on a different stretch of the vessel, perhaps at some point in the future, but any given area of the vessel, we get one shot at it. And so that's often a conversation that I'll have. Are things bad enough right now that we want to fire our one shot this time, as opposed to waiting or doing medical management or doing Botox or things like that? Moving on to joint contractures. This is also something that's unfortunately commonplace, and it's thought to be a combination of decreased blood flow on the palm side, which sort of makes the skin less stretchy and it pulls the finger down. And then we know the middle knuckle of the finger, what we call the PIP joint, is very intolerant of sitting in a bent position for a long period of time. And sometimes there's a compensatory hyperextension at the big knuckle, so you get the hand in this very dysfunctional clawed position. And then with that hand in the clawed position, with the blood flow already being reduced in the setting of Raynaud's, sometimes patients will get ulcers on the back of their middle knuckle, what we call the PIP joint, or they'll be more vulnerable to trauma. if the ulceration on the backside gets bad enough, sometimes the wound can go down to the bone. And if the wound goes down to the bone, sometimes the bacteria that normally live on the skin can get into the skin and can get through the skin rather, and even get into the bone and get a bone space infection that we call osteomyelitis, which not only is a risk to the finger, but sometimes it can even travel up the hand and become a risk for systemic infection. Now, the good news is, even in this circumstance, sometimes we can salvage the finger. It's a more involved process. It involves one or more trips to the operating room. It may involve many weeks of IV antibiotics, but at least sometimes we can, remove the most deeply infected bone, do a joint fusion where we actually lock the bone in a more extended position with temporary pins through the skin that we remove later. And then that creates enough laxity in the skin on the backside that we can then close the wound. Like any operation that I offer to my scleroderma patients, it's not perfect, but if the alternative is amputating the finger, most of the time we'll at least try that. And the good news is many times it does work. So in summary, there are a number of ways that the hands get affected in patients with scleroderma. Many of the things that warmth and local wound care can prevent or minimize many issues. There are things that surgery can do if the symptoms and exam findings are severe enough to warrant it, but that's always a well thought out incision that I take the time to have the discussion with my patients. Is now the right time that we want to do something. So thank you for your attention, and I welcome any questions.
Thank you, Dr. Lifchez. I think I've just unmuted myself. And you guys are welcome to unmute yourselves. As you want to ask a question, please feel free to. Go ahead, Barbara.
Thank you. That was a very interesting presentation. You mentioned local wound care. Do you have any recommendations for ointments? I've had a calcinosis ulcer for over a year. And right now, I don't really want it to heal because the calcinosis has come to the surface, but wound care, treatment.
So, and this is something that often my rheumatology colleagues are kind of the frontline people doing this. Oftentimes we'll use a topical antibacterial ointment called mupirocin or Bactroban. It's not the greatest in promoting wound healing, but it is very effective at subduing the staph bacteria that normally live on your skin. So it's kind of a trade-off. Other ones that we'll sometimes use, there's a brownish ointment called Iodosorb that's a little bit better for wound healing. The downside of it is it's brown and it rubs off and it can stain your clothing or your furniture. So not everybody's fond of it. And you'll often have to use a dressing over the finger so that it doesn't stain clothing and furniture. None of these are perfect. They're all generally designed to do one or both of keep bacteria that live on your skin at bay with respect to the wound. And then number two, promote a moist environment so that to whatever degree your finger skin cells can do cell division and or contract to try to bring the edges together, they can do so. So those are generally the main classes of local wound care that people do.
Thank you.
You're welcome.
Dr. Lifchez, I had a sympathectomy obviously done on my right hand from my middle finger.
Yep.
From what I hear you saying then, if I have a problem with another finger on this hand, it's a no-go?
So I apologize. I don't remember exactly which arteries we worked on your hand. Based on what I usually do, which is to say wrist level and then the specific finger, depending on which finger would become affected in the future, there is at least the possibility of a different area on the artery. So I wouldn't go back to an artery that I've worked on before, but depending on the finger that's affected, there may be one or both arteries to that finger specifically that we could work on. So it's sort of a second shot, but really it's a shot in a different place. And this is part of, for the patients that it works for, that I get a lot of value out of Botox because it buys us time before we have to do that, with the caveat, number one, some patients are having to pay for it out of pocket at $600 a pop. And number two, it doesn't work for everybody.
We tried the Botox when
Yeah.
From my, and it didn't work for me, but the surgery sure did. So
Well, good.
that was a godsend.
Yeah. Well, I'm glad it is still working for you.
Anybody else?
Is it okay to take the nifedipine in the winter and stop it in the summer?
So it's a good question. So are you saying it's because your symptoms are less severe in the summer and you don't think you
Yes.
need it? I
Right.
don't think there's any systemic risk. I don't think you're going to get like rebound high blood pressure. Most people who are on nifedipine, the dose that they're on is very low when you compare it to the dose of nifedipine people who are taking it for high blood pressure take. And therefore, I would still have a conversation with your rheumatologist, but if you're taking 5 milligrams, 10 milligrams, or maybe even 30 milligrams a day, that may be safe to do, but I would have a conversation with your rheumatologist just to make sure they know. And if they say, yes, that seems a reasonable, safe thing to do, I certainly understand the goal of taking no more medications than you have to.
Okay.
I just want to mention that I have used mupirocin and iodosorb, and they've been very helpful.
Great.
The iodosorb is a terrible stainer, but
It's messy. Yeah.
it works.
I have a couple questions.
Yes, go ahead.
One of them is I do have very bad contractures and the calcinosis and the Raynaud's. With the contractures, when do you make the decision to get your finger, what do you call it, where they extend it and it's going to be locked in that?
The joint fusion or arthrodesis.
The fusion, yeah.
Yeah. It's a good question, and I don't know that there's one answer that's right for everyone. When one starts to see an ulcer forming on the back of the knuckle, I at least have the conversation about it. The other discussion I have, and this is typically always a discussion that I want to have in person, just so that I can lay hands on your hand and get a sense of the quality of your skin, is I do want to make sure that there's enough elasticity, enough compliance in the skin that I won't create a problem. Something I worry about when somebody's knuckle has been bent down at 90 degrees is, even with removing a portion of the bone in order to be able to extend it, the arteries, which are towards the palm side of the finger, aren't very stretchy. And I always worry about, what if I stretch them too much and basically make them sort of choke themselves off, and the risk of actually creating a dead finger. So if there's an ulcer, I'll generally talk about it. Or some of my patients just have very bad dysfunction. If they can't get their fingers away from their palm, they can't hold anything. And so, yeah, I can kind of see that in the image that you're showing. And so we'll have the discussion. And for me, the main discussion points are, number one, the risk of anesthesia for surgery. Generally speaking, I do surgery for my scleroderma patients either under just local anesthetic at the finger level, if what we're doing is small enough, or what's called regional anesthesia. And what that means is an injection up at the shoulder level, ultrasound guided, done by the anesthesia doctors, that makes the arm numb. And then we put an IV in you and we give you just a little bit of twilight anesthesia. If you've had a colonoscopy or an endoscopy, it's that level of anesthesia. Specifically, we want to keep you breathing on your own, able to what we call defend your airway. Many of you have very limited mobility of your mouth, and we don't want to create a circumstance where you can't breathe well enough and we're thinking we need to put a breathing tube in. We want to prevent that from being necessary. So that's number one, making sure we can give you a safe anesthesia. And then number two, having the discussion. It, knock on wood, has only happened to me once on one finger on one patient that I've ever operated on, but it was a very bad day for both the patient and for me. And so I have that discussion of, understand we're taking on the risk of what if, the God forbid, of your finger turning black happens. And so those are the two main things we talk about when we're asking the question, is today the day we're going to make the decision to do this? Generally speaking, I like to do my elective surgery on scleroderma patients in the warmer months. That won't surprise you. And I generally try to avoid surgery other than for urgent circumstances. Somebody has an infection or something where our hand is really forced. I try to avoid it roughly December through February. I think somebody has their hand up. Ms. Trice, I think you have your hand up.
I don't know. I don't.
Oh, I thought sorry, that's my cursor. I apologize.
Cecilia. Go ahead,
Okay.
Cecilia.
Yeah, I have a question. Is there anything that helps to prevent the stiffening of the skin on the hand and the pulling of those fingers?
So from a blood vessel standpoint, there's not a lot we can do other than medical management. From a skin quality standpoint, I'm a big believer in emollients to whatever extent that you can tolerate. Now, I don't think which one you use is particularly important. And I mean things like Eucerin, cocoa butter, Vaseline, things that aren't necessarily very expensive. It gets a little complicated if and when you get an ulcer, because we do worry about it getting into the ulcer and sort of heaping up there. Not that it's dangerous to the ulcer, but if you get enough Vaseline heaped up in an ulcer, it can start to look like pus and make you nervous about is something bad happening. But so emollients can at least help to some extent maintain some suppleness of the skin.
Thank you. How about the fingertips as well? They seem to, I guess, kind of shrink is the way I would put it, but is there any way to maintain that fingertip part?
Yeah, the Sclerodactyly, or the penciling the fingertips, unfortunately, that's a blood flow issue. So to whatever extent one can preserve blood flow, whether that's with medication or whether that, if you're in that lucky subgroup where there is something I can bypass and improve the flow into your hand, those are the two main things. Even though it shows itself at the tip of the finger, it's an outcome of the blood flow going into the hand.
Got it. Thank you.
You're welcome.
One more question. Have you ever, or have you, I know it's in trial, it's called Lifchez.
Mm-hmm.
Raynaud's, I was in a trial for that, and I had good results from it. Mm-hmm. And I know in some countries they can, actually it's approved, they can go in and get it.
So that's something that is used at Johns Hopkins. It's generally managed by the rheumatologist, though. So as a surgeon, some of the patients who I follow have received it, but that's generally run by the Scleroderma Center, the rheumatology attendants. So Dr. Wigley or Humbers or Shaw and those folks. And for anybody who doesn't know, just things to be aware of, it's an infusion. It's generally done over 3 days. So there's a bit of a production to it, but yes, some patients have had very good results with it.
Does exercising your hands help at all?
So adapting what I tell my arthritis patients, movement helps preserve movement. As obvious and self-evident as that may sound, I do believe it. And so the converse of, I would not tell any of my patients to stop moving their hands or to splint their hands other than in the setting of an injury. Keeping them moving helps keep them moving to whatever extent they can.
Okay.
I tried several times to have physical therapy.
Mm-hmm.
It did not seem to do any good for me. Does that work for anyone, or?
Once you've lost motion, unfortunately, no, your odds of success are pretty low. In preserving motion, whether it's formal physical therapy or just, warm-up exercises that you just do for 5 or 10 minutes when you get up in the morning, preserving motion, there's some benefit of that, of doing, home stretching routines. Once you've lost it, though, no, unfortunately, PT doesn't often have a lot of success in getting it back.
I have one other question. I saw
Yes.
this a long time ago, and this is surgical. I don't think it was Johns Hopkins. It was somewhere, I don't know, surgeon. But instead of just fusing them, he actually took and put some kind of I don't know if it, you know, I don't know. It looked like some kind of padding or something in the joint. And so it didn't actually just fuse it solid.
Mhm.
Is that?
So those exist. We would use the general term implant arthroplasty. So some are made out of silicone, some are made out of a polymer of carbon, some are made out of metal and plastic. More commonly, I'm using those in my patients with rheumatoid arthritis or osteoarthritis. The main thing I worry about in my scleroderma patients is an implant by definition isn't alive. And unfortunately, with the skin envelope that I need to heal around it, it makes me very nervous to put a permanent implant inside the finger of somebody with scleroderma because I have to take away parts of the bone to make space for it. And if that implant were ever to be exposed, unfortunately, there's generally no uninfecting it once it gets infected. And then if I have to remove it, now not only is there a wound, there's the space inside the bone where the implant had been, and I have to get that to heal. So in my hands, I will generally not recommend joint implants in the hands for my scleroderma patients because of that risk. I worry a lot about that risk.
I have a question.
Okay.
I wanted to know, like, I've had a lot of hand amputations, and is there any adaptive equipment that you know of to help us in any way? Because like at this point, like I got 2 fingers on one hand, and then the other hand's only got 3.
So the short answer is yes, they do actually make prosthetics for individual or groups of fingers. It's a little bit trickier in patients with scleroderma because we worry about breakdown of the skin at the junction with the prosthesis. But yes, there are prosthetists who specialize in hand prostheses. So they do exist, and it's, I think it's at least worth having the conversation with them. A lot of these are silicone based, so they're relatively soft, and they're kind of a long suction cup is how they adapt to the finger. But the main worry is what if it makes, what if it creates an area of breakdown? But yes, they do exist. And then depending on where you live might be where you'd have to go to find somebody who has that area of expertise. But there are prosthetists who do make finger prosthetics. Okay. And then
And Barbara has a question.
I'm sorry, go ahead.
Barbara, do you have a question?
You're still on mute.
You need to unmute yourself.
I just wanted to make a suggestion for people with the skin problems. I load my hands, both of them, with bag balm. It's basically a medicated Vaseline. They put it on cows' udders in the wintertime to keep them from getting frostbite or whatever. And then I put on cotton gloves. So if you have an ointment, even if it's orange or yellow or what have you, the gloves prevent it from getting on other things. With this ulcerated finger, I've learned to make a dressing, a tube gauzing, and put antibacterial ointment on it, and then push it down over my hand, and I cut a hole. I cut off the finger of that glove, so the dressing goes through the glove hole, but I have the hand protected. Just a suggestion.
Very adaptive.
One of my biggest problems is, my fingers are curled, and right now I don't think I can go for surgery for this. But the problem is in the wintertime, I'm in Pennsylvania and it's cold, and I can't get gloves over these hands. I can't do it. Is there anything you can suggest?
I mean, other than unfortunately either larger size or mittens, those are the kind of the two things. And for what it's worth, when some of my patients do choose to have the joint fusion, like that's one of their rationales for doing it is I can't get gloves on to keep myself warm in the winter. But in the meantime, if for other reasons it's not safe to consider that, larger sizes or mittens, unfortunately, are kind of our best options.
I don't think that's going to work for me, but maybe it would work.
Fair enough.
Already
It
have
is a tough
large
problem.
hands as it is, and with the curled fingers, I don't know that I'd even be able to get them into the mittens. Be great if I could, but
that's a true point.
I went to Scleroderma day that they had at Hopkins several years ago, and one of the freebies we got were these glove type things, and it has done wonders for me because you can put one of those cold packs up under here, and it has worked wonderfully. It was a freebie by somebody, I don't know who.
Okay.
a good point. Thank you.
They're called wristies. They're called wristies, and you can put the hot pack in the back. They're called wristies.
But your fingers are exposed.
Yeah, they are, but I can't wear a glove, so that's the best thing I can do. Hold on just a second. Yeah, my fingers are bent, so I cannot wear a glove. So having the pack in my wrist here helps a great deal.
The ones I have, the pack goes on the back side, so it actually heats the whole back of your hand, which then keeps the fingers kind of warmer too.
Does anyone else have questions for Dr. Lifchez?
No, but thank you.
I have a question. My hands are more sensitive to the heat than they are to the cold. Do you run into that with many scleroderma patients?
That one I have not seen. I've seen one or two patients with a cousin disease called Scleroderma, which is not exactly the same despite the name sounding similar. And one of their symptoms is their Raynaud's-like phenomenon really just has the red flare. It does not have the white. It does not have the blue. And when they have the red flare, it feels hot and it's very painful and it's very sensitive to heat. On one of those patients, we tried Botox. I'm not sure whether or not it worked or just the environmental weather changed. So I don't have nearly as much experience with that.
I do have one more question.
Yes.
I was in a trial, and that's a long time ago. It was called the Satori Star trial, and they took your fat and then they shot them in your fingers.
Yeah.
It was not successful.
Yeah.
But are they experimenting with that anymore for scleroderma?
So were you one of our patients who we treated at Hopkins, or were you treated somewhere else?
I was in Los Angeles.
Okay. I would say we treated 3 or 4 people at Hopkins that I was a part of. It was very disappointing because the European data really looked very promising and the risk of doing it seemed pretty low. You know, and by the way, you got your thighs liposuction to harvest the fat, so people like that.
I didn't need that,
unfortunately, the data just didn't pan out that it did any good. You know, and at the time that it came out, you know, in the medical community, we were saying fat-derived stem cells can do miracles in lots of places, and this is just one more. Unfortunately, when we actually did the measurements on how the patients did who got treatment versus placebo, unfortunately, it didn't do it, which is disappointing because, again, we really don't have ways to undo the fibrosis once it happens. I'm not aware of other trials on similar things that are currently ongoing.
Did you say that people with limited scleroderma get it more than diffuse?
Get hand disease. Statistically, that is true.
Is there a reason or just?
I think it is in part what is the phenotype of limited scleroderma, which is to say it is more extremity related as opposed to what we call diffuse scleroderma is more internal organ affecting. So some of it is just the definitions that we use to make those terms.
Okay.
And have they tried, oh, I can't remember the name of the chamber, but they do it a lot where you go in this chamber and then it really,
Hyperbaric oxygen.
hyperbaric oxygen.
Yeah, unfortunately, that's one of the things that sounds appealing, but doesn't work as well as unfortunately, it's a fairly short list of things that hyperbaric oxygen works for. It works for some inhalation injuries and burn patients. It works for the bends in scuba divers and other areas. The reason it doesn't work for most other medical conditions is most of the oxygen that's going to get to tissue anywhere on your body is coming with a hemoglobin molecule in your blood. And the amount of oxygen that's dissolved in your blood is typically less than 0.5% of the oxygen that's getting there. Hyperbaric oxygen can only change the amount of oxygen that's dissolved in your blood. So it's proportionally, even if you believe that it's working, it's making such a small difference in the added amount of oxygen that gets to the tissues. That's why we think it doesn't have a measurable effect. I see Kim and Jeannie have your hands up if either of you want to ask your questions.
I'm just sort of wondering about braces for my hands.
Okay.
When I sleep at night, my hands are quite twisted. And my occupational therapist suggested maybe custom braces because my index fingers trying to, when I sleep at night, cross over the top of the other ones.
Okay.
To hold it in place and separate them just while I sleep. Do you think that would be like a good idea or?
So in theory, the things that it could help with, number one, if you have discomfort when the fingers cross over, it may prevent that. Number two, if the finger is spending a lot of time bent in sleep and the knuckle is starting to get stiffer in flexion, it may slow the pace that flexes more. So it may do either or both of those things, provided it's padded well enough, provided you look closely to make sure it's not rubbing and making wounds and that sort of thing.
Okay.
And then Jeannie, you had a question?
No, I was just going to make a comment. In the past, when I've had digital ulcers, my rheumatologist prescribed the nifedipine in a compounded cream that I would apply to the sides of the digit, like my index finger.
Or nitro paste.
Pardon?
Or nitro paste.
Okay, yeah. So I would apply that to the side of the fingers that are generally affected 30 minutes before I would go out. And it seemed to have improved the fingers so that they wouldn't sort of get so cold so fast and cause a lot of pain.
So for some patients that can work well. There are two main caveats that come with it. Number one, it's not a manufactured medication, so you have to get to a compounding pharmacy that's willing to make it for you. Number two, in some patients, it's going to get absorbed and you may still get the systemic side effects, low blood pressure, dizziness. So in some people, it works well. And again, typically, this is something that the rheumatologist will prescribe. Other than those two, well, one risk and one inconvenience, it's a reasonable thing to consider. The one comment I'll make about nitropaste, whereas nifedipine and things like that are designed to dilate arteries, nitropaste actually more effectively dilates veins. So it's a little bit higher risk of lightheadedness and feeling dizzy. That being said,
for about a half an hour. It was really painful for about a half an hour when I put it on ulcers. And I wrapped it, but it was really painful for about a half an hour and then it would settle down.
The upside of nitropaste is that is manufactured. So you can get that at a regular pharmacy. You don't need a compounding pharmacy to get it. So it's a little bit easier.
They're expensive.
And the other thing that I would use to keep my hands warm is I bought battery operated glove liners that I wear in the winter, and they come, I could wear them either wireless or wired, and they work, but they're not probably aesthetically pleasant to wear in a dressy occasion, especially if I wear the wire, because it's like you wear a wire around your head and you have a lead out through the sleeve of one arm and the other arm. Yeah, it just, it looks like what kitties use, what you use to dress kitties and mittens, but they do work.
Okay.
Are we good? Anyone else have a question for Dr. Lifchez?
I have a question for you. I have
Okay.
one finger that's doing what all of yours are. Curving. I don't know if you can see that. This one.
Your
One
index finger?
finger. How long does it take till they all start doing that?
That's something maybe Dr. Lifchez can answer better than I.
Well, unfortunately, it is very variable person to person. I have some patients who have advanced Raynaud's but little calcinosis, or they have advanced calcinosis but not much flexion contractures. So unfortunately, I can't give you a generalization. It's something that we keep an eye on. It's something that maybe splinting can at least slow down the pace of. But unfortunately, I can't give you a good prediction of how quickly will your index finger bend, or how quickly or if the other fingers will start bending as well. Sorry.
So this is one finger that I had gangrene in the tip from.
Okay.
And that's the only one. But even my fingernails are starting to curve from the lack of oxygen.
Well, and the other thing that curves the fingernails is as the skin on the fingertip gets tight and pulls towards the palm, it pulls the nail bed, the soft tissue that supports the fingernail, towards the palm. So that contributes to it also.
I've tried putting pulse oximeters on my finger.
Can they get a reading?
It doesn't register. It doesn't register in any of my fingers. So I must have it pretty bad.
I mean, there is a limit to what a standard finger pulse ox can do. And yes, when we're, for example, doing surgery, many times we'll have to put the pulse oximeter on an earlobe or something like that if the fingers don't register well. That is true.
Well, I'm a nurse and I wear it at work, or I use it at work, but I've tried my own finger and it's a little scary when you don't have any register on there.
I can see that.
This is a bad disease. Yeah.
Have you tried using your thumb in the oximeter?
Really is. Yeah. I tried every single finger and they're all the same. So nothing. Nothing registers on the pulse ox. It's a portable pulse ox.
Sure.
It's not the plug-in. The plug-in would probably be better.
Perhaps.
It's scary, a little scary. Yeah.
A question. Does the same thing happen with your toes? Do they kind of bend in? Because I notice my toes are getting, I don't know what the word is for, but like thicker or kind of like fat, so to speak. You know? And the bottom.
Similar blood flow issues can affect the toes. I'll be honest, I don't see those as often. Those typically get seen by my colleagues in vascular surgery, but yes, it's a similar phenomenon of these are the arteries that are the furthest away from the heart. They're already the smallest to begin with, and if you add to them scarring and blood vessel spasm, unfortunately, the tips of the toes, in a similar manner to the tips of the fingers, are most vulnerable to it.
We overproduce collagen, right?
It's a little simplified, but yes.
Okay. That's what I was told, that I overproduce collagen in the blood vessels.
In the tissues immediately surrounding them, yes. So there are a lot of different types of collagen. Type 1 and 3 are the primary types in scar tissue. And yes, so when I talk about the patients who have had scleroderma for a longer period of time and who don't respond as well to the Botox, we think that's part of what's going on, is they have relatively more collagen, relatively more scar tissue around the blood vessels, so that even if you can get the muscle part of the blood vessel to spasm as much, because there's already extra collagen there, the blood vessel can't dilate, can't get bigger as effectively.
What causes the calcinosis?
So we think the calcinosis is a local phenomenon related to blood flow. Now, how does low blood flow turn into the calcium in the blood spitting out into the skin? I have not come across a paper that's explained that very well to me. But we believe it is a blood flow related phenomenon, plus or minus local trauma. And trauma doesn't need to be like falling down on your hand. It can be minor trauma too.
I never saw that yet.
Okay.
I had a suggestion while I'm on unmute to Galaxy Tab A. I don't know what your name is, but you're listed as Galaxy Tab A. Have you tried hanging your arm down at your side when you use the oximeter?
No, I have not.
I had a heart attack last June, and that was how they got it. I hung my arm down on the side of the bed and it registered. And now that's the way I do it.
I just wanted to know, are you guys seeing any kids come with like these same issues? Like, is it just the adults? Because my first sign, I was 19, was my hands. So are you guys seeing any younger people?
Mine too, at 38.
Yeah, so not truly children, but I have seen teenagers, 17-year-old and 18-year-olds with their first onset of disease. I don't think I've seen anybody younger than 17. And even that, I think I've only seen one 17-year-old and one 18-year-old.
So if you go to get surgery on the fingers, and the calcinosis is really bad in your fingers, is that going to be an issue? My wound clinic people and with the x-rays, they say that even in some of my joints or on my fingertips, that basically a lot of the bone is gone and it's just all that calcium sitting around in there. It's like,
so, you know, if you were to come see me in clinic, I would look at your hand and look at your x-rays and talk about kind of what are the most pressing issues. Most of the time, I will not take on calcinosis and a joint contracture in the same surgery. I won't say never, but it's pretty rare. So we would talk about, you know, which parts of the finger are the most bothersome. Is it the contracture? Is it the calcinosis? Are there wounds? That sort of thing. And then we would talk about, is there something that I thought I could make improved enough that it's worth the risk of going through surgery?
Everybody's different, pretty much. Yeah.
Fairly true.
If we have calcinosis, like in our arms, will that eventually progress further down the hand?
Not necessarily. I have occasional patients who have elbow and forearm calcinosis, but thus far don't have it in their hand, or they have it in their hand and then we take care of it and it doesn't come back, but it comes in the elbow or the forearm. It is certainly higher risk of occurring in the fingertips and the tip of the thumb, but it can occur in places up the forearm. The good news is, number one, oftentimes there's still enough soft tissue padding that it's not bothersome. And if it is bothersome enough that we talk about removing it, it's a little bit easier of a recovery. The skin is generally in a little bit better of a condition that, we have lower risk of wound healing issues.
Mine doesn't hurt or anything. They just look bumpy when I hold my arm up.
Okay. And you know, like calcinosis anywhere, if it's not causing a problem, it doesn't have to be messed with.
Thank you.
Right.
Does being on CellCept have anything to do with Raynaud's at all? Like
that is a great question. I actually don't know the answer to that. My understanding is that CellCept more often is being used to slow the progression of more of the internal problems of scleroderma, but I apologize, I don't actually know that answer if it has any effect on Raynaud's.
Okay.
Well, like for me, I've had scleroderma for 20 years, and I have the calcinosis literally from my hands to my feet. Like I have them in different places. Like, so here we have scleroderma clinics, but then do you guys accept new patients, or
Oh,
how
sure.
do we get to just get a referral to you guys, or?
Yeah, I mean, I'm in my hospital clinic every Tuesday and my offsite clinic every Friday. So as long as your insurance carrier allows you to be seen out of state by us, here, I'll put my scheduling phone number in the chat if anybody wants it.
Thank you.
Do you not recommend scleroderma patients take calcium supplements?
I think that depends on what reason they're taking it for. So again, that's something I would generally defer to their medical doctor, either their rheumatologist or even their internist.
For osteoporosis?
You know, again, it depends on the particulars. Certainly, for postmenopausal women, many times calcium is useful for preventing hip fracture, spinal compression, that sort of thing. Again, calcinosis is not typically a calcium metabolism problem. So if you have a reason to take calcium for something else going on medically, I wouldn't generally be worried about it from the sake of, am I worried your calcinosis is going to get worse? They're generally not related phenomenon, even though they both involve calcium.
That's what I wondered.
Yeah.
That's a good answer. I like that answer.
Fair enough.
Does calcinosis internalize? Can it occur inside the body?
I have not seen that, not in the same way that blood vessel spasm can affect internal organs as well as the hands. So I'm not aware of calcinosis affecting lungs or liver or gut or things like that. Not that I know of is the best answer I can give you.
What research is being done to hopefully give us better outcomes in the future?
So, you know, there's clinical work being done with trials on things like iloprost and things like that. And, you know, I can tell you a little bit, you know, from a hand surgery standpoint, most of it is just reporting what can be done and what are the expected outcomes. So that sort of thing are things that like I'll do, but that's what's considered level 4 research, basically just reporting on how the patients that we treated, how they're doing. From a medical standpoint, what medications will work, those are generally done on the medical side. So through rheumatology divisions and stuff. I know there's a whole research arm to the Scleroderma Center, but I only know some of the projects they're working on, mostly the ones that interact with the hands. And even that, I only know some of those projects.
Does anyone else have a question before we wrap up?
Do you do surgery only on the hands, or have you ever had to do it on the feet too?
I would generally defer foot surgery to one of my colleagues who does that more commonly. Although my primary training is in plastic surgery, so I am trained in whole body reconstruction. For the most part, I just stick to hands.
Well, thank you.
It looks as if we're good. I want to thank you, Dr. Lifchez, for helping us out here and being a part of this. And it was very informative and really good. Thank you.
My pleasure. It was a pleasure speaking with everybody tonight.
Thank you very much.
Thank you. I enjoyed
Thank
it.
you.
Have a great evening.
Bye-bye.
Bye.
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 For those of you who are members of the group, we can hang on for just a few more minutes if you'd like. Galaxy Tab A, are you still there? I don't know what her name is, but you would ask me a question.
Jean.
Oh, is it Jean? Okay, thank you, Jean. I'm
Yeah.
sorry. We didn't have a name.
I don't know what the Galaxy is. I'm on my
That's the name
tablet.
of your tablet.
Yeah, probably
Yeah.
it's the name of your phone
It
or
is.
your tablet.
This is
You
the
had asked me
first
about my
Zoom.
fingers,
Yes.
and I didn't
My
want to go
fingers.
into it because I
Okay.
didn't want to hold Dr. Lifchez up any. I wanted it to be his for him to discuss things. But to answer your question,
Yes.
my fingers have gradually curled. I've had scleroderma for 22 years, and it's it's gotten worse as the time went on. When I first was diagnosed, my fingers were almost straight. But now, of course, they're like this, and this is as straight as I can get them.
Can you straighten them? Can you straighten them? Will
No,
they
no,
straighten?
this is it. This is as straight as they get.
Bend them straight.
No, believe me, I've tried. I've gone to physical therapy. I've done a lot of things, but nothing works.
Mine is starting to do that, and I think they're all gonna eventually, probably.
When were you diagnosed?
I was I'm 63 now, and I was diagnosed at 36.
Oh, so you've had it for a while.
I've had a long time. It's very, very slow. But this fingertip had an ulcer for a year, and it turned to gangrene on the tip. And that's the only one that won't straighten, the one that had gangrene.
Yeah. Well, that's what happened to me.
The ulcers are all, pardon me?
That's what happened to me. It was my middle finger, and it had turned completely black. It was really painful, really, really painful. And Dr. Lifchez, in fact, let me just hang on for just a second. I'm going to wrap up the recording at this point. I should have wrapped it up earlier. Okay.